It's a privilege for Charlotte and I to be here today to give you a brief update on the recent work that's been undertaken by the Trust to provide staff who care for patients who are in the last days of their life with some up-to-date guidance on what is important to them at such a significant time. So to that end, the purpose of our presentation, if I can get it to flick across and to work. There we go, okay. So the aim of the session really is to introduce you to the 5 principles to guide care in the last days and hours of life and review the guidance that the Trust has introduced to help staff with their care planning at this particular time. Oops, it is on the wrong road. Okay. Caring for dying patients has always been an integral aspect of practice for many healthcare professionals working across settings in the last days and hours of people's lives. And we always endeavour to provide skilled and compassionate care and support to the dying person and to their families. But in the last couple of years, which I'm probably sure you've already heard in the talks up to this point, there's been some concern and controversy about the standard of care that dying patients and relatives received. And you've probably heard of some of the issues that have been reported, probably primarily in the press in England. We hope that this session will give you an update on developments nationally and here in the Trust. But our primary aim is really in the hope that we can reassure you about the standard of care that we would expect for the patients who we care for here in this Trust. So a wee bit of information on the background to why we have new guidance or why we had to produce some new guidance for our staff. In 2013 there was an inquiry into end-of-life care in England, and that inquiry recommended that the use of the Liverpool Care Pathway cease. The inquiry identified some very poor practice, in particular in relation to communications with patients and families at end of life. And in fact the inquiry said they had no issue with the pathway itself or the care that it endeavoured to prompt and record. In actual fact, in the right hands, it did prompt and record very good care and very good practice, but rather they had heard of so many instances of very poor care that I think the pathway in itself maybe became the scapegoat for poor education and poor practice where end of life was concerned. So post-inquiry there was a group formed called the Leadership Alliance for Dying People, and that group consisted of professional organisations from a range of backgrounds, including the General Medical Council, the Royal College of Nurses, NICE, etc. And they had published a document called One Chance to Get It Right. And within that document there were 5 principles for practice at end of life. Now in Northern Ireland we went through a wee spell, I think it could be fair to say, uncertainty, because we weren't too sure what we were to do. And as just last summer, in fact, a number of consultants in the Trust here contacted the medical director and said, you know, we're a bit concerned. We're not to use the pathway. Staff, we I suppose in general didn't really have very much problems, I don't think, with the pathway itself. And staff valued it very much because it did prompt good care and practice, and it was a good reminder about good care and practice, and they did use it to record the care that they had given. But just almost immediately after that had happened, in July last year, the Chief Medical Officer and the Chief Nursing Officer did contact all trusts in Northern Ireland and recommended that the Liverpool Care Pathway be discontinued by Halloween last year, and that we practice, when we care for dying people, that we follow 5 principles, which are more or less the principles that were written in the One Chance to Get It Right document by the Leadership Alliance. So as I think Caroline had been saying earlier on, in some ways there's nothing new about these principles. What was always right when it comes to care for dying people and their families is still right and is still important. When we care for dying patients and their families, we need to focus on the impact of this individual's death and its meaning to all concerned, because every death is unique. And the principles for care guide us to consider the numerous contexts in which the death is happening and how we in our various roles in healthcare can carry out our duty when we are the person responsible for elements of that person's care. If we do this, we're more likely to provide care that is sensitive to and appropriate to the situation at hand. And these are the 5 principles that should underpin the care that we provide for dying patients and support a personalised and compassionate approach to the care of them and their family in the final hours. So we'll just go through them in a little more detail. The first principle says there should be timely identification that a person is dying, and probably in the final hours of life. Now this principle honours and reflects the importance of recognising in the first place that the patient is or may be dying, and that is a skill in itself. So the key points that we are reminded of is that there should be agreement. That agreement that a person's death is expected within days or hours should be based on a multidisciplinary discussion about the person's condition. The second principle is that there should be sensitive and clear communication at the centre of quality care. In the One Chance, or in the Neuberger report actually, the More Care Less Pathway document that came out in 2013, the report found that a common theme among those who had responded to the inquiry was that they were simply not told that their loved one was dying, and this clearly contributed to their failure to understand that the person was dying, which compounded their grief and subsequent distress. So it's of no surprise that this should be a very important principle as we plan our care for dying people and their families. So it just reminds us and honours that we need to honour the importance of clear and unambiguous communication when discussing dying with patients and with relatives. And that families should be reassured that even though that their loved one is dying, that there will be regular review as part of the care of their loved one. Because I think that was a criticism also of families' misunderstanding of being on an end-of-life care pathway, that they felt that they were on this pathway and they were on the road to death, and a lot of maybe things that might be done to support good comfort and care maybe would not be done. So it's important that we assure families that there would be regular review whenever their loved one is dying. The third principle says that people who are identified as dying should have their physical, psychological, spiritual and social needs identified and be involved in decisions about how those needs can best be met, etc. And this principle really honours and recognises the significance really of a life coming to an end, and the importance in taking steps to ensure comfort and to minimise distress wherever possible. Some of the recommendations in the report included that communication should be regular and proactive, and that staff should actively seek to communicate, not simply wait for the person or those important to them to ask questions, that it should be a two-way process. The fourth principle reminds us that care in the last days and hours of life should be planned and coordinated with a focus on symptom control, comfort management, and ensuring that psychological, social, spiritual support is provided to meet the person's needs. And the key points in the document that Charlotte is about to show you now underpins the importance of involving families and carers in decisions about the dying person's treatment and care. And that indeed can be a very difficult and very sensitive area. And we would, as part of this process of introducing the guidance, would be reminding staff that making the decisions and recording the decisions and having the discussions around what's appropriate when it comes to especially resuscitation, that should go hand in hand with good end-of-life care planning based on what the individual and their family need and want. The Leadership Alliance document made it clear that we should agree with dying people and those who are important to them, whether or not they're being informed about, consulted about, involved in or taking particular decisions about treatment and care. What is their level? What is our expectation of us whenever we are agreeing and planning care and with them? And as was already mentioned, food and drink was one area that was particularly criticised, or the poor practice in relation to providing food and drink was particularly criticised in the More Care Less Pathway document, and indeed was reflected on in One Chance to get it right. And steps are hopefully being taken to remind us all, I suppose, of the importance of whenever people can take a little bit of something or drink a little bit of something, that it's our duty to ensure that they can and that they're supported to do that. And finally, the fifth principle is about support for families and carers, and that should be provided during their loved ones' final days and hours and into bereavement. And I suppose in my particular role, this is one area of care that I would be particularly, advocating. The principle really focuses on what is important for relatives before death and in the period afterwards. And certainly people who are sitting at the bedside of a loved one dying will have their own particular needs. They're often tired, physically, emotionally, they may be anxious, they may be fearful. And even those families who appear to be coping very well certainly also value that the staff who are caring for them at that particular point in time regularly check in and ask them how they too are coming to terms with what is evolving in front of their eyes. And I'm sure, as has already been mentioned, the things that people appreciate very much are being prepared gently for what is about to happen, being involved, helping in whatever way they can with the physical care and support of their loved one, explanation of the actual dying process and the changes that take place, all things that families will tell us is very valuable to them. And that we as healthcare staff regularly drop in or pop in or be physically present and alongside them whenever they are going through this very unique and difficult experience. And certainly when the death happens, the things about that families will tell us, well, that they value very much time with their loved one in the immediate period after death, that they get an explanation about what actually happens next from the point of death and beyond, and that we make efforts to provide them information and advice on the practical issues that arise whenever someone dies, the things that they may need to attend to after death, such as taking the death certificate to the registrar, a little bit of information about dealing with grief and bereavement, and where they can get help and support down the line should they need it. So that's just a brief review of the 5 principles, and Charlotte will explain a little bit about the guidance document that's been drafted based on those points. Okay, Charlotte.
Thank you, Jan. Try not to completely destroy all of the stuff up here. Thank you. So, as Improvement Lead for Acute Services, I've had the privilege of helping to coordinate and facilitate this piece of work along with our Assistant Director for Improvement, Nita Carroll, and a really fabulous working group, I have to say. And it really is a privilege because whilst I have a clinical background, I certainly don't come from a palliative care background, but you don't get involved in a piece of work like this for too long before you have a really vested interest in it and you appreciate the importance of it and how essential it is to have really good care at the end of life. I think you realise how relevant it is to all of us. Certainly it makes you think a wee bit more, I know that. So it's with great delight I'm able to introduce you to our Southern Trust Guidance for Personalised Care Planning. This piece of work was commissioned by our Director of Acute Services, and in the first instance, as Anna said, it was commissioned for acute out of a recognised need. We quickly brought on board our non-acute sites, but certainly we recognised from the outset that it wasn't an exclusive problem for the acute and non-acute setting. And we would hope that with the work that we're doing and the audit that we will subsequently do, that this is something that will be appropriate and relevant to roll out across the Trust. The working group was established in September of last year, and we had representation and tried to get representation from as varied areas as we could, certainly across both sites, Daisy-Hill and Craigavon, and from our non-acute colleagues. We had medical input, nursing and clinical input. Certainly we owe a lot to our palliative colleagues, and Tracy and Dr McLaughlin were both very much involved, Anne and Aileen and myself, and really it became a very vibrant and busy group. What I would say is, before we go through the document, that this is a live document. I think by the time it arrived on the intranet, we were probably at version 14. So it changed a lot, and it was a very fluid process right through. And we anticipate that it will change more as we take on board guidance and input from staff and feedback from staff. We would anticipate that it will change to meet the need of staff and patients as we move along. So I'll briefly take us through the document if this works, and it does. So we've just got a snapshot of each page of the document. You can go onto the Trust intranet site under the palliative care section and download a complete document. But just to give you an idea of what it looks like, as Anne has already stated, the purpose of this is to provide guidance and support for staff caring for patients in the last days and hours of life. So really the opening page is on how to develop a personalised care plan, and this shows us a wee snapshot. As you can see, it opens with guidance on how to determine if the document is appropriate in the first instance for the patient, and if they're actually reaching the dying phase, and that very difficult question that has been mentioned and discussed. It clearly states for staff that the decision must be made by senior doctor and senior nurse, and that where there's any uncertainty in whether the patient has reached the dying phase, a second opinion should be sought, and it constantly signposts staff back to our specialist palliative teams for guidance and for a second opinion where they feel it's appropriate. It highlights discussion and communication at all stages of the process, and it also the importance of documenting all communications, and that's key right through the document. It highlights the regular review of the patient and offers guidance of when the diagnosis of dying may need to be reconsidered, and that again, that very difficult question, if things don't go as we have expected them to go, which is so often the case. And also it gives very clear recommendations around resus status, and that's something that's already been mentioned. We are advocating that if the decision hasn't been made around resus, the patient should not be utilising this guidance, and we're very clear on that. The next section is on discussing dying with patients and their families and carers, and it's right up there at the start of the document. And I think if we've taken anything from today, it's around communication, and that's a common theme that's coming out through everybody's talks. It's a one-pager, this is just a snapshot of the first 3 points on it, and it really offers guidance and support on how to discuss dying, which is no easy feat. We know, and it's been mentioned constantly throughout today, that communication is a particular issue. And you will see, and I hope you'll appreciate that right through the document, if you can get your hands on it and look right through it, and there's some copies at the back, that it is consistently alluded to right through the document, the need for good communication and clear communication at all stages. And so we thought it was essential that we provided a focus on this right at the outset, and that's why this page is there. It provides 6 key points to form the basis of discussion for staff to encourage them to feel confident in discussing these issues, and that's one of the things. We recognise that it can be challenging for staff in a busy environment, and also challenging for maybe less senior staff to be confident in taking the time to discuss the change in the focus of care for the particular patient. And we hope that these points help guide those conversations around the shift in focus to comfort care, symptom management, support, removal of unnecessary or burdensome interventions or medications, maybe a change in the frequency of monitoring of vital signs, and helping both the patient, where appropriate, and the relatives understand how things such as breathing or interest in food and drink will have changed. And it also aims to reassure staff that predicting a decline in a patient is very difficult, and that it's okay, and indeed it's correct, that this uncertainty should be acknowledged with the patients and the families. So this is a really important part of our overall guidance document, and was very clear from the outset that it would be included. The next section is really around the key principles, and I won't go through them because Anne's covered them really very clearly. But we really wanted to provide training guidance to staff, highlighting that the guidance that's here is really underpinned by those 5 key principles. As a group, we cross-referenced these against various documents, some of which have been mentioned already today. The One Chance to Get It Right document, the General Medical Council document around end of life, Department of Health, Living Matters, Dying Matters, and the Department of Health Strategy for Bereavement. So this is included to make it very clear where these principles come from, and to reassure staff around the guidance that we're giving them. And you'll notice from this that each principle includes actions that can be taken that will guide staff's actions, such as making the decision by a consultant or senior clinician, that assessment should recognise and explain to the person, family, the uncertainty, and timely and sensitive discussion. Information should be provided about what's likely to happen, so it guides staff as to what they should be doing. And again, this is for each of the 5 principles. Then, into the nitty-gritty of the guidance. And this changed a lot throughout the process. We went round the houses with this one a wee bit. And we had to be really, really careful about not developing a pathway, and that's already been mentioned and touched on today. And it was really difficult, very challenging. We needed to produce something that was supportive and it provided guidance, but didn't look like we were putting a patient on something or commencing them in something. But we wanted to work this into some sort of reference or guide that staff could actually lift and utilise, that would be useful for them, not just words on a page, and that would act as a prompt for good care, and indeed maybe a checklist for good care. And we know that there's a huge amount of evidence out there to suggest that checklists are really useful. Like there's a long history of the usefulness of checklists in healthcare and through lots of different industry. And we felt that we finally ended up with this as our what we're trying with staff, and certainly our feedback will determine whether this is what it looks like in the long run. So you can see that we have a medical checklist. This is in the bulk of the document, but can certainly be lifted out separately and included in the medical notes. And really these prompts for care down the left-hand side are around prompting initially the diagnosis of the dying patient, but then on each review of the patient, their case review. Have all reversible factors been looked at? Has the decision been made that we think they've reached the dying phase? Communication, again, is right in there at the top. So once that decision has been made, has it been communicated to the patient, to the family? And really underpinning all of this. Symptom review, have distressing symptoms been addressed? And we really tried throughout this to move away from the negative terminology of have things been stopped, have things been discontinued, have we changed medicine? And we're looking at what needs to be done. Has everything been reviewed, and anything that's not essential been stopped? Are we giving them what they need in terms of interventions? What's now appropriate? What's no longer appropriate or no longer required? And we believe that after a lot of discussion and a huge amount of input from our medical colleagues on the group, these 9 points: diagnosis, communication, symptom review, medication review, interventions, hydration and nutrition, our DNS-CPR status, whether there's an ICD in place, and psychological, social and spiritual input. We believe that guides care, and the aim would be that doctors would lift this, an initial assessment can date it, but that it would form a prompt for each of their interventions with the patient. Similarly, we developed a nursing checklist, and they both evolved quite differently and then ended up coming back to look quite similar, which is great. And again, the same key messages coming across. Nursing staff in particular, it's probably fair to say, really probably missed the LCP document, really liked the guidance that it provided for them, that it gave them a very clear, something that they could tangibly use with patients. And so the nurses had a big input with developing this checklist. They felt it was something that they could lift. It can be lifted out of the document, slotted into their existing nursing care plans, not instead of the care plan, but as an aid to the care plan. So the prompts are there, but all of the input with the patient is documented in the existing notes as they would be. And again, it prompts communication as being number one. Are the patient family care aware of who the lead is? Has a full explanation been given? Is everything recorded in the nursing notes? Because we know it has to be written down or it didn't happen. Pain, comfort and agitation. Quite simply, is the patient comfortable, pain-free and not agitated? At each review of that patient, can we tick that box and say that's been done? Breathing, have they any noisy chest secretions? Consideration of that, is it comfortable? And it's about giving staff the confidence around checking these things and then discussing these things with the patient. And we've gone through mouth care, pressure care, personal care, elimination, medication, any other physical care needs, their emotional needs, and their family and care needs, really trying to hit every box that we could think of that was important and relevant to the patient and the carer's needs. And you'll see at the bottom of each of these pages we have said, consider the support of the specialist palliative care team. So constantly reinforcing that if you're in doubt or if you have a query, don't be afraid to go back and seek advice, and certainly seek advice from a specialist team. We know that not every patient will have input from our specialist team, because that would be impossible, but they're there as a reference point and certainly are happy to answer any questions. And then towards the end of the document, and this is, I think, the bit the staff really felt in a little bit of a vacuum without the LCP document, around the guidance, the symptom management guidance. And so it's very important that we've included this, and it was really great timing actually, because this was reviewed regionally in October of last year, and so we were able to include it in our document. We are happy that it's the most up-to-date version, and staff, I think, feel very comfortable that it's there, that they can avail of. And it goes through, this is just one wee page of it, but we're covering the management of pain, management of nausea and vomiting, management of breathing, shortness of breath, management of chest secretions, and management of agitation. And those things are so crucial for staff, and in particular staff would have mentioned even in the out of hours period that they can lift this and they can go to it when they need to know what to do to make a patient comfortable, which is so essential. And just to round off the document, and I suppose to ensure that we were being really looking at the full journey and holistically at this, there's a section on care after death. And really the section gives staff guidance on how to deal with the patient's relatives at obviously a very difficult time, and the situation that they're dealing with following a death, but also how to manage and care for the deceased patient, which is so important. And I've learned so much from Anne in relation to this actually. And also including their statutory responsibilities, what they're required to do at that point in time at ward level. So I hope that gives you an idea of what the document covers. The guidance at the moment is that it's placed in the medical record, so it can be downloaded from the intranet, placed in the medical record for all staff, HP staff, etc., to look at and seek advice from, and the assessment section can be lifted out and added into the nursing notes or into the medical notes, and copied as they need to be. And moving forward, I suppose we're hopefully coming out of that really fraught winter pressure time, but we're really trying to maintain our engagement with staff and get it out there, get the message out that this needs to be used. It has been presented at our M&M meetings, or mortality morbidity meetings, by our consultants, palliative consultants, which is great. And certainly we're going to attempt to monitor the standard of care via our M&M meetings, so that'll be a rolling audit of that. And we're also looking at auditing the use and effectiveness of the guidance, and that's something that we're looking at the moment. So is it in the notes? Is it being used? And also how effective has it been? Engaging from staff, how useful it is, and getting their feedback. Could it be slightly different? Is it laid out wrong? Is there something we're missing? And we're going to gather and collate all that information. And finally, just the use of technology. We're very keen that this wee symbol, which Anne will keep me right on, is a symbol that has been used elsewhere, isn't that right, Anne? Down south for the hospice-friendly hospitals. Yeah. But interestingly, we'll know that on our wards we use the electronic whiteboards, the IMIC system, and within that system they actually already had used the symbol elsewhere somewhere, and they had approached us that possibly we could use this because currently there was LCP written on the IMIC screens and we want to get rid of that. So we're very keen that we'll be able to use this symbol at ward level to identify those patients. It gives us a clear audit trail of those patients, but also potentially that moving forward we might be able to utilise this symbol at ward level to indicate that there's a patient who may be dying and that staff would be aware of that, and people moving in and out of the ward would be aware that we can really think about our actions and noise levels. Yeah. Mortality and morbidity meetings. So we have nursing and medical M&N meetings where they'll discuss all the cases of patients who have deceased. And up until this point, I suppose it wouldn't have been highlighted out of those patients who would have maybe been in a end of life phase or maybe on the LCP previously.
So is this monthly meetings? Or?
Yes, they are monthly, are they, Caroline? Yeah, yeah, yeah.
So you discuss all the patients that
They
are
do.
deceased,
And Daisy Hill, yeah,
Daisy Hill.
yeah, they do. And they'll pull out certain cases potentially that they want to discuss at the minute. I mean, the doctors would help me more with this, but they would discuss certain cases where there was learning from and certainly discuss what happened. And we'd like our patients who have been identified as being using this guidance, that they would also be discussed, that we can see that there's a clear, if there's not a stop, that it follows through, that we can improve care as we move along. And I'll hand over to Anne just to finish off. Thank you. Try not to stand.
Just finally, this is the, whoops, it is, oh, this is the last slide really, just to round up the presentation. In the introduction to his book, Love and Loss, Colin Murray Parkes, that some of you may have read some of his work, he writes that when the death of a loved one is predicted, we can grieve for their loss before it happens. But he goes on then to describe that there's an important difference between the grief that comes before death and that which comes afterwards, because he observed that the grief which precedes loss intensifies the attachment and the greater preoccupation that relatives can have with the person who is dying. So that being said, really, it I suppose gives us all the more reason that we endeavour to provide care that leaves relatives and the dying person in no doubt that we understand how they may be feeling and that we communicate with them and support them accordingly. And we hope that this guidance will be helpful for all our staff to do just that. So thank you very much. Thank you.